Good day, my name is Neil Falk. I'm with RPIW 29. Our team name is Serenity Now. We are working to a attack time of 20 minutes, and we were reporting out on attack time of 20 minutes. So this is our picture. So all of our wonderful team members, and it was a wonderful team. So what we started with was, we see that through our RPIW project form, we actually see about 70 to 80 patients in outpatient mental health psychiatry, and throughout that time they continue to miss the targets on the provincial measures. And so what we tried to do is we tried to shorten the time from the time the referral came in to the time the actual appointment was with the psychiatrist. Understanding where we could make some changes is in some of the no-show rates. There was a no-show rate of 36%, and so we worked on some of those processes. So our baseline target sheet, where we made some improvements, where we were looking for was in our space. That was the actual desk space and the space of the storage cabinets and some of the file and folder cabinets that were there in our mail functions. Inventory, we had 21,000 pieces. Some of our triage levels that we were trying to get to. Our 5S score is there as well.
Hi, my name is Jane Amprine, and I am team lead for RPIW number 29. So I just want to address our attack time. It was based on 6 months from August to September, and so it was for the process of getting the referral through to making the time of the appointment, and that was 112.5 minutes per referral. The current state value now actually was showing us that it was from the time that referral was received, or the client's referral. I want to always remember that when that referral comes off, it's not a piece of paper, it's a patient and their family. So when that referral came off of the client's referral came off of the fax machine, to the time that we made the appointment was for 22 days, and that was actually getting the appointment with the psychiatrist. It was 22 days, and I can't read, it was 49 minutes, 44 minutes. So the 22 days was the outstanding for getting the actual appointment with the psychiatrist. And you can see that we did have, some challenges that we wanted to address and make it better for our client. This was, as we started, this was our ruler wheel, and we had 20 items that we wanted to address.
Good afternoon, everybody. My name is Cam Friesen, and I was looking at the intake process of the referral. Right at the beginning, I came up with an idea summary, and one of the biggest issues that we had was not one of the biggest, but there was some lack of information on the referral. So between the management, we sent another referral letter requesting the physicians, the referring agents, to try to complete the information. It's either done or in process. Good, thanks. So what we also did was we were going to be looking at calling the client and confirming their appointment. So what pre-Kaizen, they looked at some, they took some times, and from the very beginning of the referral when they first received it to the time that the psychiatrist seen. What it was is basically, we found out that there were 13 examples taken, 22 days, 49 minutes, and 44 seconds for the average. During this time, we also tried to evaluate from the percentage load chart how much time this referral spent in each hand. And with the MOAs at that time it was 11 minutes, and with intake work it was only 5 minutes. So you can see in the spaghetti chart the numerous movement from the intake workers as well as the MOAs going in different parts of the MOA area, which added a lot of steps. This is just an example of where the referrals used to go once an intake was done, and it's waiting for appointment time. It'll come up a little more clear now. That was clear across the room. So then after post-Kaizen, after we started doing this things that was for just a sample, we reduced that time. Not so much days, we remained 22 days, but where it did make a difference was the minutes, 21 minutes and 52 seconds now. You'll see why a little later. Right here is where you're going to see it. See now, on the spaghetti map, there isn't quite as much movement. In fact, the next picture I'll show where we used to put them in the referral bin, or the referrals used to go on file cabinet, now it's right on one of the MOA's desks, so it's right there. So again, now with the percent load chart, instead of the MOA having more time with that referral, the actual paper, the intake now is spending more time with it and actually doing some work with it. We set up a work standard for contacting clients before their appointment. We did it dry run on it 2 days before the referral, and so we're going to try to implement that also. Contacting the client before the appointment. Multiple skill training, as you can see on the right-hand side, some of it is done and it's going to be continued. I think they actually have an end date for that all to be done. So it's going to include the MOAs as well as the intake.
Nancy Kirchner. I was working with Michelle on the scheduling team for this. We were working on 3 cars at first. That was also highlighted by our dear sheet, which is basically the psychiatrist currently not meeting intervention 12 times for triage 1 to 4 patients. But we also understood that meeting these targets currently as it is very difficult, because we came to the realization that patients that the psychiatrists are seeing in our walk-in services, emergency department and on medical levels were not being captured at all. We also recognize that currently there is no standardization for the way the psychiatrists are scheduling their appointments. For instance, there's different working rules for psychiatrists, different appointment times, often confusing to the MOAs. So we looked at the outpatients intake process as well as emergency department. In looking at our walk-in or outpatients process, we met with the manager, Jennifer Supero, as well as the intake supervisor, to talk about redesigning our current agreements, our walk-in screening form that we were using, to capture some of the triage data, which was currently only being done for therapy patients. So with the help of the manager, the supervisor, the intake team, as well as the IT department, we've been able to actually completely eliminate the screen form. And IT was redesigning a new form for us that was based on an existing electronic screening form. So this form is now usable for psychiatry, but as well for therapy and addiction services. This is just a mock copy, but it will be an electronic drop screen. The great benefit of this as well, we were trying to design a form to capture the triage data that was missing. It basically actually simplifies the process for the therapies and addiction services. And we've got now one instrument that will actually fill in multiple functions. One thing that could not be completed during this week is completely finalizing the psychiatry schedule. So we have a meeting set up in early December. And during this meeting, we will talk. One of the psychiatrists did agree to change the intake appointment time. So this will give us a first step towards standardizing the new intake appointment times. And perhaps eliminate the step of having one or more person involved in doing this intake screening for us. Michelle will talk about the emergency department.
My name is Michelle Hartsuder, and I am a participant on RPIW number 29. And as Lindsay stated, that the data we were capturing was not complete, and our full RPIW and the targets are based on that information, so you can see how great the need would be to have accurate information. We started from that with an idea sheet that would focus on capturing that data. So as you can see on the top, if we're seeing 3 people in emerge right now, and we're seeing 1 person in outpatients, in our data, in the metrics that are input into the system, we're only capturing 1 person, whereas post-Kaizen we want to capture all 4 that received. So we came up with a change to the psychiatric consult form that will be used in emerge and on the levels. And it includes a process to enter the data that will now be provided from it. If you turn that a bit, you can see There's a section for notes, so we're not changing the consult form at all, first page, so that will remain the same. We're only adding a second page, which is for the use of the psychiatrist only. Where Neil was pointing there, the psychiatrist will now indicate the psychiatric triage level, so that will be able to be entered into metrics. And also the second section is the psychiatric consultation outcome. So if you need an appointment following seeing a physician on the levels or in the emergency department, that is going to be indicated there. Also indicated there is who will book that appointment. So, we skipped ahead, but on that form at the bottom, it shows that the ward clerk in emergency will now fax that form back to the mental health outpatient unit, which was never done before. So it will go directly to the intake worker's email, and he will be able to enter those metrics into the system, as well as indicate whether it is he or one of his counterparts, or if it's an MOA that will book the future appointments. The work standard was developed for this new process, and it was rolled out to the MOAs, to intake. It's in the process of being rolled out to the psychiatrists, because they also need to receive some education on how to assess for triage level and indicate that on the form. We were able to meet with Sharon Griffin to talk about rolling it out to emergency. And luckily, she's a just do it kind of person, and she said, let's go. We went over to emergency, we started rolling it out, though it won't be ready to use there just yet. We already started warming the soil, and the staff were very receptive, as well as the physicians and nurses and ward clerk there. And then on the next page, you'll see the multi-skills training checklist. Oh, no, you won't. You can imagine the multi-skills training checklist that we use, but really the data will now be in the metrics for use by the region, and in order for us to submit provincial data for reports that are required. And through the improvements, we'll be able to understand the client's needs and really what our true capacity is to meet these needs with the resources we have at hand. As a team, we're very cognizant that each metrics, scheduling spot, and referral piece of paper is representative of our clients that really need our services and who are a priority in forging ahead with these improvements.
Hi, my name is Lori Prince. I am on the 5S'ing team. Here you see a layout of our office. The highlighted areas are the ones that we 5S, basically, changed or removed. This is because this is before picture of our office. This is the after picture of our office. We removed mailboxes from the wall that you would have seen in the first picture, and we're putting up a 4x7 whiteboard there for visual viewing, daily visual viewing. This is our desk before, and this is after, and we're still working on it. We once walked across the office for paper supplies, basically white paper, and we had colored paper situated right beside the photocopiers. So we changed it all about, put the white paper, colored paper, bottom drawer has toner, so it's just 2 steps away from the photocopier. This, again, is going to be our biz wall, our daily wall that we will be communicating on, and we'll be putting like target goals and if we've reached them or if we haven't. And we also have a work standard. The MOAs will be updating the board daily with our appointment sheets of who's on call, who's on intake, who's on faxes, etc. And this is our training checklist, which the MOAs got trained on, and
I'm Gail Bear, 5S team member. My work was not here, but I was doing movement of files and cabinets. The mail cupboard from main floor taken off wall and moved to unused office, which has been converted to mailroom. Restructured nurses' mail slots, moved to mailroom. Moved 3 steel cabinets to mailroom, will contain old face sheets. All mail slots are labeled doctors in one area. Charts in bucket with numbers placed on cart wheels. 4 2-door cabinets holding obsolete information stored in mailroom. Journal book stored into steel cabinets. So that was my work for the week. But the flow is improved. And when the flow is improved, there is value added time for the clients.
My name is Colleen Toy, and I was very privileged to be part of the RPIW number 29 as a participant. And the 5S team did cover a lot of territory. We also looked at a couple of supply cupboards, and the pictures really reflect just one of those cupboards. So we removed all the non-used and non-usable items from the cupboard, and we either discarded, redistributed, or we recycled the items. We referred to, there were some items that were obviously obsolete, but then we referred to staff if we weren't really sure what to do with the items. Then the cupboards were cleaned. We organized all the remaining items and labeled them, so we had an inventory reduction of a little bit better than 50%, and we had a space reduction of about 17%. We created work standards, and they were posted with our post pictures as well. And you saw the multi-skills checklist that Laura had shown. And we also created an and-on, that's the next one, Neil. And it's also posted, it's on the standard, or work standard, but, no, it's wrong, sorry. This and-on really is a clear visual for staff to clearly see, to put the old supplies to the front and put the new supplies at the back. And the work standard really addresses the maintenance and the audit of the supplies. We didn't get to management of supplies, and the staff have clearly indicated that they'd like to move to a Kanban system, so hopefully that can happen. So our gains with the 5S, initially it was a 2.1, and we managed to get it to a 3.0. And the gains were really in sorting and labeling and reducing that inventory. And the supply coverage has become very visual. They can see when supplies are missing, when they're needed. And as importantly, they can see when supplies are really quite overstocked.
So as you can see from our motor wheel, that we started with 20 items on, and we able to eliminate 7. And you know what? Vanity's got to get out. That's much better. So, anyway, this is our interesting map. And I just want to actually, just from listening to what everybody else has actually said through our team, is that we've really done a lot of positive work. And we, because we haven't had time to measure a lot of those audits, if you look at our, our lead time, it doesn't look like we've done a lot, but there's, as you can see, we've eliminated some of the things that we wanted to work on, and I think as we move forward and during the audit period, we are going to start seeing gains for all of the really positive hard work done. I can't see this very well, so Neil, can you just read it out for me?
So inventory reduction of 51. So with the inventory, we actually had a reduction of just 51%. Where parts traveled with moving paper, we actually got a 93% improvement through a productivity gain without having to actually re-enter a lot of the demographics through multiple areas. We've actually been able to reduce some of them, or get some productivity gain of about 50%. We have reduced our setup time by 49%. And capacity, we really didn't get to measure. The capacity that's here is for one psychiatrist and only one psychiatrist over a 2-week period, and it includes her travel time and all of those value-added processes that were there, but they're not included in their capacity.
Okay, newspaper I can deal with. So we had 16 items on our newspaper, and we actually have completed 10 of them. And in the next, during the audit period, I am confident that what we're leaving open on the newspaper will be resolved. So we've been pretty successful.
So with all that we've accomplished today, I think the key is we've set a foundation for continuous improvement. There's information that's being gathered that will help them in the next RPIWs moving forward. What we did find was, from a summary, was the need for data. You can't measure, or you can't change something you can't measure, and we haven't measured. Communication is truly key to the process. Without communication, although we did communicate, more communication is always necessary. We also look that all roads lead back to the client, and it's all about improving the client care that goes on in our mental health group. So I'd like to give a great round of applause for all the people that helped us through, and there was many people within the mental health area, in the psychiatry department area, that helped us through this process, and so it was truly a department effort and a team effort. And so I want to thank my team as well. They're a wonderful group of people that just threw themselves into the process. I want to thank Sensei and Narita for helping us through our challenge that we came to this week. So